Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Deanna began scanning almost 15 years ago. She scanned as a general ultrasound tech, but also as a traveler since 2016. She loved being a traveling ultrasound tech. She did local and national. She was kind of bullied into the ultrasound program at the school that she was going to, but didn't even know what ultrasound was before she entered the schooling. But she eventually pushed through and was able to get her bachelor's in healthcare leadership in 2018. She now is just in love with her career. She loves volunteering for fostering animals, traveling, hiking trips, and she's a plant enthusiast. Please help me welcome Deanna Donch. Deanna, thank you for joining us on our podcast today to talk about surgical ultrasounds. So tell us a little bit about yourself and why you might have chosen to get involved with or start doing ultrasounds.
So my story, like we were talking about earlier, my story with ultrasound is super, kind of think it's actually kind of hilarious. So I actually was going to school downtown Pittsburgh to be a medical assistant. And I had no idea about ultrasound, like whatsoever. So I had never had one before. I had never really known anyone that ever had one. So when I went to the school, they had basically were like, listen, like, you need to go for the ultrasound program. So I was like, okay, like I have no idea anything about ultrasound. So I took my prereqs, I took my classes. So initially when we had gone into the the classroom, we had to have 60 college credits prior to being admitted to the program. So, there was like very intelligent, amazing people in my program with me. And it was a 2-year program, obviously. And so like, I had no idea what I was getting myself into. Like, I literally just like, was like, oh, like somebody would have told me I had to take a physics board. Like, no way. Like, that's very, that's so intimidating to hear.
Right.
Or just like boards in general is just very intimidating, especially like what they're doing now with the ARDMS. So I think that's also just kind of another, obstacle that is a little bit intimidating as a sonographer is like, oh my gosh, I didn't know what I was getting myself into, because a lot of people, and I'm sure right, are just saying, oh, ultrasound babies.
Right. Yeah.
And a lot of that is
they think about, right?
Yeah. Exactly. And so a lot of that is, okay, well, yes, we can offer that, but what happens behind, those closed doors, to speak? So what happens after, you get that diagnosis? What happens when ultrasound confirms those CTs, or ultrasound is that first round and then you get a CT that confirms that? So what happens after that,
Right.
And so it's really, really amazing turnaround for my career to be able to say, I was able to see what happens on that other side of things. So it goes from bedside. Yes, we diagnose, the radiologist reads, they recommend their other, alternative imaging to confirm.
Right.
Mm-hmm. And then we go into, the gallbladder removals, the Whipple procedures, the splenectomies, the, radical kidney surgeries where they remove tumors or the partial nephrectomies or a whole radical nephrectomy, where general surgery comes into it's so much to where, I think that regular sonographers, bedside or general or whatever, what have you, like our role is so important. And that's almost what I want to highlight to this is like, I was a general sonographer, I was a traveler for years. And it's so important for us to be able to say, yes, there's gallstones. And yes, I threw them left lateral to cube. And yes, they're mobile. All of that stuff actually matters.
Right.
It's not just like we're
Yeah.
saying that for fun to be able to
Right.
say, like, yeah, it was mobile. Like a lot of that really matters because on the other side of that, it goes into the OR and it goes into the doctors. Like that matters to them. So,
Absolutely. Everything that we do does matter, it really does. So, which is awesome, right? Because I talk to friends who are in IT and they don't really have a sense of purpose or meaning all the time with what they're doing. Or I had a
mhm.
friend once who scheduled advertisements for radio stations and scheduled did a schedule for the radio station. She goes, how meaningless is that, right? She always thought my job was really cool because it provided purpose and meaning
Mhm.
and direction for people. And I think we take that for granted sometimes,
Right. Especially when we're at bedside, where we're working those odd shifts, or maybe when we're getting called in. And
Right.
it's those nights where we're very tired, we're very over it. We're very much like, oh my God, they're calling me in for another right upper quadrant, you know. But, and I think that's where, and because I've been in that position,
Sure.
I'm
Everybody
sure
has.
any of us have to where, I don't want to be called in. I don't want to go in. It's 2 a.m. Can't they get a CT? Like, what
Right.
are we going to tell you? We've all
Right.
had that same thought,
Right. Right.
is, oh, what are we going to tell you that a CT couldn't? Or
Right.
what, like, come on. Like, you don't need me to come in the middle of the night to tell you this. Like, especially even with like blood clots, like give them a shot of, uh, blood thinner and let's see them in the morning. Like it's not like they even treat blood clots a little less than they do even just like kidney stones
Oh, wow.
or
Hmm.
gallstones. So the transition between seeing that as bedside and as a traveler, and even just like learning what ultrasound was, like I knew I loved people and I knew I loved ultrasound, like not ultrasound, but I just loved to, like, I never wanted to be a nurse. Like if somebody told me I had to
Right.
draw blood, like good night, I'm done. Like I couldn't. Like even those cardiovascular echo techs, I'm
Yeah.
pretty sure they
They draw blood.
right.
Yeah, do the contrast. Yeah. Yeah.
Yeah, they're saints. I could never do it.
Yeah.
Too much for me.
I agree with you. I think it was very appealing to me to be a part of a team. I didn't want to be the main doctor to have to throw down the gavel to make the
Mhm.
official diagnosis at the time. Um, but yeah, I loved being a part of the team, right? And I loved somebody looking at things objectively and
Mhm.
being able to say, oh, well, let me try that again, or let me try this again, or, you know, and working together to get an answer or a diagnosis.
Exactly. That's a
So,
lot of what healthcare I think is it's not just one person doing all the work where you've got, and I think a lot of people, the general population thinks it's just this one test or it's just
right,
this one person or it's just this one doctor. Like they don't understand that their PCP may be sending, okay, great. Like you came into me with X amount of problems, issues, concerns. Well, I'm sending this out to like
right,
six other doctors that can really actually hone in on this problem. So, I think a lot of people I think due diligence
right,
is what might actually be really saving a lot of the medical community right now. Is a lot of people are real like the ability to look things up,
right,
the ability to have access to all these different options and these different facilities that have this amazing, it's not just, oh, these ultrasound techs, great, that's awesome. Like, of course, I love my like what would they do without us?
Right.
Right, at bedside. But when it comes to surgical ultrasound, like, they desperately need us. They wouldn't be able to do the surgeries they do, especially at a non-radiation level, where we're able to say, like, hey, I can come bedside. But a lot of us as sonographers, like, oh God, we hate getting pulled to go to the OR.
I
Those,
love the OR.
do you?
I love the OR.
So what do you do when you go to the OR?
Well, I don't now because I'm traveling, right?
Sure.
But when I did go to the OR, I was doing fetal surgeries with fetal surgeons.
Oh.
And so for me, um, it's almost like holy ground to me, right? Like we're all scrubbing up and we're all going in, and it feels like we're all like checking our ego at the door, you know?
Mhm.
And I could be all scrubbed in with the doctors, and and I try to explain this to some of my friends who go to surgery for like a broken arm or shoulder, or they've had different things. And I'm like, oh my God, surgery is such an amazing place to be. And they're like, what are you talking about? I'm like, because you've got like 15 people in this one room, all eyes on you. Like we document everything. We have to make sure
Mhm.
the temperature in the room, and there's fire precautions, and there's like so much detail to what we do in the OR as a whole global team of
Mhm.
maybe 15 people, that there's nothing too good or bad about anybody. We're all there trying to do the same thing, you
Exactly.
know? And all of a sudden, I'll say, my glasses are falling down my nose. Can somebody push them up? And some stranger
Right.
comes up and pushes them up, right? Like it's just to me, I just love that a group of strangers who all know their part
Mhm.
show up together to make this a success. And we dot the I's and we cross the T's and we take the time out and we're all on board.
Mhm.
And most of the time everything goes well, right? And we hope and pray that that's how it goes. Occasionally things go south, right? Which we're then also prepared for. Right.
Sure.
But um
That's why we are where we are.
yeah,
We are
it's
prepared for
just
that. We're in the mental stability. We're physically able to deal with it. We know what to do if, God forbid, it goes
right,
to a point that we all need to go hands on deck.
right,
No, we work together. And you're right, exactly. Like the OR is not a place for um whatever is on the outside of things. It's just solely about that patient, about that
right.
care, and about that doctor and exactly what he needs or
And
they need.
people listen to you, and you're encouraged to speak up about little
Yes,
things and any kind of concern. And I just think it's an amazing time of teamwork with people I don't even know.
you're
You know,
right.
it's just to me an amazing process, right? I love it. And we've done some amazing things in surgery, and we've just come such a long way. And then after talking to you and hearing more things, I'm thinking, wow, what else can we do?
Right. The door is just open for all.
Yeah. So let's talk about the first thing of general surgery with gallbladder, liver, pancreas, and spleen. I'm kind of interested in this for a couple different reasons, and so we'll talk about it as you go through it. But you're saying on the other side of our diagnostic ultrasound, there's ultrasound in the surgery unit while they're doing these procedures. Is that what you're saying?
Correct. Yep. So when I would go into surgeries, they would basically have us bring in these very minimal surgical ultrasound units. So there was very minimal features. As a sonographer, there's no buttons, right? Like you're just like, okay, do there's no
Oh
buttons.
gosh.
It's so baseline. Like it's like depth, depth, your gain, your
Yeah.
color, your Doppler. I mean, you get
Okay.
these very basic, features
Right.
um that you get in. And and setting these ultrasounds up. They're not like our general ultrasound units that we would use in the department or our general lab or vascular lab. These are things that they use plug and play in the OR. So they are completely different platforms. They are completely different units. They are very much like plug and play. So
Okay.
for a sonographer, I come in and I see this, I'm like, what am I looking at? Like this is what, like, there's certain units that make sense. And you're like, okay, once I get the general idea
Right.
of this, like as a sonographer, I understand what we're going for.
Right. Right.
Um, but they are surgical units. So they are not meant to give you that cine. They're not meant to replay imaging. They don't have the track balls. Like they're
Right.
very much plug and play.
Okay.
So when someone goes in for, let's say, a cholecystectomy, that, let's say it's an open one, so they're actually cutting them, which is like kind of rare. But they'll bring in a regular, like a T probe ultrasound where they can hold this surgical probe by their fingers and
Okay.
say, yep, we're okay, or no, let's, like, it almost looks like this, they can hold it like this. It's a jade roller for my face.
Okay.
This is actually just one of the what one of the probes looks like. So you could
Okay.
actually, like, say this was the left, aspect of the liver. Okay, they could put it exclusively on that and say, yes, I have
Okay.
re-enable, and let's put color flow on, and
Okay.
let's
Make
make sure that
sure.
we have patency and color flow in the left renal vein, the left,
Yeah.
renal artery. Let's make sure that we have patency with that. So I've seen that being done, and there's been times that they just put it straight down on somebody and they're doing stents in the gallbladder, um, where I wasn't even acting as a sonographer. I came in to support the case, to just bring the machine.
Right.
So those doctors actually are the ones that are operating the ultrasound,
Right.
be able to
Right.
move it and say, hey, I see that stent, or I don't see that, or can you move the depth or whatever. So they're
Right.
actually the ones that are operating. So it's a little bit of a different environment, of course.
Sure.
Of course we're in the OR as sonographers, so it's like, there's certain people that love it, like maybe
Right.
you and I.
Like crazy me. Yeah.
Yeah. Yeah, and like as a traveler, I think people love that for you, and like for me, like I love to go to the OR. Send it to me. I will go portable. As a traveler, like I know that that's what regular. As a sonographer, I hate going portable, but as a traveler, I will go portable for you because I understand that's going to get me kudos, and I don't mind doing it. So like I'm okay with that. Like they don't want to go portable, they don't want to go to the OR, they don't want to do these things. So I'm like, whatever, I'll go.
Yeah, I
you
didn't.
know
Yeah.
and they almost, like, I feel like they
So
almost like
tell me,
me
how
better.
does the ultrasound help, like in a Whipple procedure? Have you been involved in that?
Yes. Yeah.
So how is that helpful then? How do
So
they
they
do?
actually use, so a Whipple procedure, they actually, it's an open case. So they
Right.
actually open the patient. And then whenever they go in, it's a very long procedure. It's about like between 6 to 8 hours, depending on, if it's an optimum, patient.
Yeah.
But I actually was shocked to be able to see a Whipple procedure because, as we know, as sonographers, the pancreas is such a malleable organ that it will just, from what I've understood, it just kind of like falls in between your fingers. So
Oh,
to be able to be on a forefront to watch a Whipple procedure felt really amazing. They basically open the patient and they put the probe like right down on the
top of
pancreas.
the pancreas. Yeah.
Mhm. Yep, and they connect the ducts, the GDA and the CBD. They connect it again, where they may actually do like a splenectomy. It just kind of depends on what the grade of issues are with the Whipple procedure, but it does take several hours. Like it is not something that they just casually do. I mean, it's an 8-hour surgery, but it's
Yeah, my
definitely
dad
done.
had a Whipple procedure.
Your dad did.
My dad did about 29 years ago. So I don't know if they
Whoa.
did ultrasound then or not during surgery or during the Whipple. He had pancreatic cancer. And so I have several friends. Well, I have one friend presently who has pancreatic cancer. And
Oh.
so, that might be in his future, unfortunately. But Yeah, just wondering how that ultrasound really helped. It's just a probe that the doctor uses to put straight down on top of the organ.
It depends, yeah. So it depends on what they're doing in the surgical, their surgical room. There's some cases where they pop it in robotically, and there's some cases where they have an open, procedure to where the surgeon can actually hold the probe and say, and they're not like a curved probe that we're used to, or a linear probe that we are used to in a general lab. Like these are totally different probes that are specifically made for a surgical
Proceed.
ultrasound unit. Like they
Yeah,
are specifically made to go into a drop down, into a drop down for a robotic surgery or for a surgeon to physically handle. So these probes are things that we wouldn't typically see in a general unit, but they're so interesting because they're so useful, they're so pertinent, where you take a probe, it fits in between. Like I said, with this is like my little jade roller, right? But it's like very similar to this size, where and even just the doctor can,
yeah,
if it's a, let's say we're using the liver, right? Like you can
right.
just do your signs, and some of these probes are
So what
you
are
get.
the frequencies of the probes then?
So it depends, right? That's an awesome question. So some of the surgical probes that I've been exposed to have a higher frequency exclusively because they're dealing with, you're putting it right on the organ.
Right, right, right,
So you don't have to penetrate through fat, the adipose tissue, whatever else you may have,
right,
even if the organs are just fatty, you're
right,
right there. So you get the most pristine pictures of the kidneys. You can see the calyces, you can see the ducts, like you can see these, like it is the most gorgeous picture you'd ever see as a sonographer.
right.
First
Yeah,
kiss.
textbook, right?
Yeah.
If not better. So tell me how it's used with a Da Vinci.
So the
Because
Da Vinci, so
this is
there's actually
how
several.
narrow-minded I was, right? Like I work in OBGYN and they use the Da Vinci to do hysterectomies, right? And I've worked with older doctors who have been really hesitant to learn the Da Vinci because it's like a video game, right? Now,
Mhm.
younger doctors is very much
Yep.
more hands-on and easier to use. Um, but how is so then when I hear, oh, the Da Vinci's used in this, that, a whole smothering of different surgical procedures, right? Um, so how is ultrasound used with robotics then?
So with the Da Vinci, I mean, it is that robot. I mean, that is going to be the future. That is going to be the future, and continually, I mean, that's right now. We're going to see even better, amazing, more outcomes for patients, I think, with robotic surgery. I mean, like you said, it is very much like a video game, right? Like the doctors sit at their console, they have their arms that articulate to the robot. And there are several different types of Da Vinci robots where there's a single port, which is kind of rare, where we see they just make like one incision in the
Right,
patient, and
right,
that's it. It's like a 1 3 inch incision in the patient, and that's it. Where they find like their soft tissue. It's
right,
primarily where I've seen it used is for like partial nephrectomies or radical nephrectomies, and they have like a bubble, right? So it's like it's like really like a miniature, like the guy in like the man in the bubble, that John Travolta movie. Where
oh,
he was
okay.
the guy in the bubble, like they have that. It's literally like a bubble that sticks out on a patient during the middle of a procedure, right? So they put this in there and it opens up and it's this bubble. So they can put the pathology in there, they can put lymph nodes in there that they excise, all of these things without compromising the patient's, sterile field, so to
Right,
speak.
right.
So, you see these Da Vinci machines in a lot of different, general and urological, surgeries where, you think like, you have these tiny little holes, but there are all these intricate arms that they control from, like you said, like a video game console.
Okay,
So
okay.
there is a learning curve when it comes to doctors who are, like you said, like the older ones that are kind of stuck in their ways. If they're not, you know, um, if they're not opposed to learning Da Vinci, like if you get them earlier in their career, like you said, like they're
Right.
going to be fantastic, like surgical doctors throughout
Well,
their
I
career.
think the older physicians can do it. They just need more practice,
Right.
right?
And they're so
So that they're
rigid. Like you said,
comfortable.
like a lot of them can be
That they're
very
comfortable.
rigid.
Well,
Even
they're
just
a lot
learning.
like us, right? Like once we
Mhm.
get in a way that we're good and we know we're good doing it this way, we don't like to change it, right? Like it's like, why change what's working,
Exactly.
right? And so they're just like us. But yeah, it just takes practice. So
Yeah,
awesome.
but it is
So
very much like you said, like they look like, and like the OR is almost like any normal place you would kind of go to. It's kind of like very much more lackadaisical than you would think. Like, of course, they care about their sterile field and
right,
what they're
right,
calling in for the doctor. And anytime he speaks, like it's silent, but like
right.
they play music. Like, have you bet like to the
Yeah,
OR where they play
yeah,
music and it's kind of
yeah.
like, okay, like I guess this isn't as nuts as I thought it was. Like it's so serious.
Well, I think it's serious, but they use the music sometimes to kind of lighten the mood,
Hmm.
to lighten their load, and to kind of enjoy their work, right? It's just
Right.
like anybody else would play music while they're washing their car or something.
Right, like it's just a job. Like it almost kind of, I don't want to say it like makes it just be just a job, but it almost kind of like when you're in the OR and you're just like, okay, like I know what I'm doing. I know
Right,
exactly what I'm here for. Like my job doesn't vary. Like I listen to the doctor, period. Like,
right,
so it's so interesting because everyone has their exact role that like if you don't skew from it.
right.
So kind of like, okay, like they're playing music, like, okay, it's okay. You don't have to be
Yeah,
so
yeah.
stressed.
So you
Because
were
people will tell you.
mentioning the kidneys.
Mhm.
So, what it describe to us the space or?
Okay, so SpaceOAR is actually in our urological procedures, right? So prostate cancer is pretty prevalent, especially because we all know that men don't want to go to the doctor. That's like a big thing with men, especially when it has to do with something down there. So they're very hesitant. But when we go in for these procedures for urology, for our prostate care, it's a lot of these prostate biopsies, which is so important. And I know that, like, what man wants that, right? But like the importance of getting those biopsies and the importance of making sure you're ahead of that is absolutely integral into your future healthcare because as we know, prostate cancer is something that will metastasize quickly if it's not, dealt with,
Right,
right? So,
right.
so the SpaceOAR is basically okay. So we did a biopsy. We know that you have some type of cancer. So what they do is they'll insert. So say this is the prostate. What they do is they'll insert a needle right in between this and what's called the rectal hump. So
Okay.
they'll actually place almost like the best way I can explain this is like if you have lip filler, Botox, lip filler,
Oh,
right?
okay.
If you ever got filler, okay, what they do is they push this filler kind of like a gel inside of between the rectal wall and the prostate capsule, okay, and so what that does is act like a little refraction. So
Oh,
once they put that in there, say you have a base or an apical, say you have a base to mid gland tumor, okay, we'll just say this is the mid gland right here where my finger is. You place the spacer like this, that ends up being able to say, all right, we're not doing any more damage to the rectal tissue, the colon, X, Y, and Z. It kind of refracts it back to
okay.
the posterior aspect of the prostate as opposed to just letting the radiation just kind of go with it, we're out
Okay.
without.
So they're able to be much more specific of where the radiation goes then.
They try to with these procedures, so the spacer or there's like a bio protect balloon that they can actually adjust, so they can put it in and they can actually adjust it. So like, okay, yeah, we have this is base tumor, but let's move it to like a mid gland apex tumor, something, let's do it this way. So they're able to actually move that. So it's a little more mobility when it comes to different types of, not just a space or like a biogel or a barogel. There's other options out there that I
Right.
think especially when they move forward with prostate cancer or any cancer really,
Right.
they'll be able to use that technology to just isolate those cancer, even if it's a metastasize, they can actually, or metastases, they can actually really get into that and say, we're harboring in on this gel refracts that right back into the tissue itself, you know. So I think it's awesome, but there's times where you see a SpaceOAR where it kind of migrates, because like filler, I don't know if you've seen this on just you see this in anybody these days, right? Filler will migrate. So it migrates in their
Mm.
face. It gives, if you see that with people, they get their lip filler and it like makes them have those duck lips.
Oh, okay.
If you think about that, like it migrates. So with
Okay.
SpaceOAR, that's kind of where I've seen a lot of physicians have an issue where, that SpaceOAR will do that. So where a BioProtect balloon is a better, and I don't obviously endorse either one of them, but, where I see physicians go back in and they have to readjust and they
Okay.
can't because it's a filler versus a
Okay.
bio balloon.
Okay. That helps.
It does. It does. But, I mean, I think obviously they're coming out with different things every day. So things are different all the time. So I'm interested to see because this is definitely something that they have talked about before. So within that space or, realm, and I know a lot of doctors that love it when it's placed correctly, it's fantastic. But there's those options, or there's times where, surgery doesn't go the way that
Right.
the outcome isn't always what we want. And unfortunately, sometimes that happens with space wars
Yeah.
or, any other, filler type of, radiation therapy that's trying to block that. I mean, I guess you can only really put it where you think it is, but
Right.
in reality, it may need to be adjusted. So,
And they use these probes are more end fire or
so the probes are very interesting.
okay.
Um, that was probably one of the hardest things that I had to get used to as a sonographer. So we take a probe like this, right? This is our probe. We
Yeah.
put it down on the patient. We know that it's imaging sagittal now. Well, let me turn the probe. It's transverse.
Right.
But with these probes, a lot of the surgical probes, it's something where it's one sagittal crystal and then another transverse crystal. So a lot of those things you don't see a lot of end fire where like they call it end fire. They call it side fire. They call it biplane, right? So there's all these different names for these probes. I'm just like over here, a little confused as a sonographer. I'm like, what are you talking about?
Yeah.
But there's certain probes that do certain things.
Okay.
So, like a biplane probe would be a probe that they would use to insert a SpaceOAR probe.
Okay.
But like a surgical probe they would use is going to be completely different. It's going to be this tiny little probe that they poke in through their Da Vinci port. And so all these probes are differently and specifically made for
Okay.
those exact OR cases. So, there's prostate cases, and even with transrectal versus transperineal cases, they
Yeah.
use different probes for that as well.
Wow.
Yeah, it's a total different world to try to like, as a sonographer, to kind of wrap your head around that and say, oh, you're doing a transrectal, like, oh, you're just doing a side fire case. Like, I don't know what are we saying? Like, what is that?
Yeah. Okay.
Side fire means nothing to me. And
Yeah.
so like when other people are saying that I don't actually know what it is, it's just like, oh my God, what does that mean? What do I need to bring? And a lot of those doctors, you're working with urologists, you're working with radiologists in the
Right.
actual, there's a
Right.
lot of
In the
different people
OR.
that come into play for that.
So, tell us about the technology behind your how do you say URONAV?
URONAV.
URONAV.
Yeah.
URONAV. Tell us
Yes.
about that.
URONAV. I'm excited about URONAV actually because I think the technology behind URONAV can be used to not just treat prostate. So, the technology behind URONAV is amazing. It's super interesting. So, what happens is, say the candidate, their prostate, they have a high PSA. They've had a regular 12 core biopsy, which a lot of us don't see as sonographers, prostate stuff.
Right.
Um, so they have this regular 12 core biopsy, which is kind of like invasive, very invasive. As a sonographer watching this happen, I think it's very
Right.
invasive.
Right.
And then they do this 12 core biopsy, or they say, yep, this is an area that we think is, you know, that's this area that might be a little bit worse than this area, but we have 2 or 3 areas that we think are higher in a cancerous cells. So what
Okay.
they do is the radiologist or a urologist could, but it's typically done by a radiologist. They draw the boundary of the prostate in all the slices of the MRI. So it's, every slice they're drawing, because it's almost like a sagittal or, a superior to inferior view.
Okay.
So they're chopping it up in every little slice, and they're saying, okay, this is where I'm seeing it. It's mid transitional zone. In prostate cancer, transitional zone is like where 70% of it is, of the
Okay.
cancer is. So, we're able to really hone it in and say, yep, it's in the anterior transitional zone, or it's posterior, or X, Y, and Z. So what URONAV does is really hone in these biopsies and say,
Okay.
the whole gland may be compromised, but these are the areas that we think could actually be the worst.
Okay.
And so what the doctors can really do is go in and do these transperineal or transrectal biopsies and do very targeted, explicit biopsies to say, I pulled the lateral aspect of this biopsy, and then I did a mid, and then I did a medial aspect. So I could get, and a superior and inferior to say, like, okay, I got all of these aspects of this small, tiny tumor. I poked all of these aspects of it. So they have very concentrated biopsies. And then for them to be able to send those off to the lab and say, okay, this was this was that, we have this in the, transitional zone, the right anterior transition zone, then they can really hone in that, that prostate cancer, or how they're going to treat that. Is that something they need to do HIFU for? Is that something they need to do brachytherapy? Should they even get radiation? So they can really address the issue from there.
Okay.
Yeah, it's amazing. It's amazing. It's amazing technology. And I genuinely think that, once that gets transitioned to not just prostate, but that can be applied to kidney tumors, right?
Right.
Liver tumors, thyroid, even breast tumors. I
Yeah.
mean, if we can grade them from an MRI, why can't that technology be applied to all of these other cancers, to where, people are dying at an exponential rate over this, that especially with COVID, I know, there's probably a backlog with a lot of patients,
Right. Right.
and that's not fair to anyone to.
So tell me a little bit more about this brachytherapy.
So brachytherapy is very interesting. It's not something that is just accustomed to with just men. It is something that women can also have as well. So if they have cervical cancer, um, vaginal cancer, uterine cancer, this is something that, and Laura Berg had actually kind of talked about this a little bit. I listened to her podcast. Fantastic, by the way, I must say.
You did a great.
Wonderfully done, wonderfully spoken about, like wonderful education. That was a fantastic podcast. Well done,
Yeah,
ladies.
she did a good job.
But she definitely highlighted a lot of very integral parts of not even just giving birth, but female health, that a lot of people just don't think about, right? So these surgical ultrasound units, like within brachytherapy, that can be really, honed into the gynecological aspect of things. It is done with prostate therapy, a lot of that. So there's low dose radiation and there's high dose radiation. So with the low dose, that's where they implant like I'm sure we've all heard of somebody who has had prostate seeds implanted.
Yes. Yeah.
So
Yeah.
that's low dose radiation. That's
Oh,
low dose.
okay.
And they use ultrasound during that entire procedure.
Okay.
Um, and they plan that staging within like with I'm sorry, not physiologists. Oh gosh, they are physicists. So
Okay.
they are the smartest people that
Yeah.
I've ever.
Yeah, they're all pretty smart.
Like, what do you say
Yeah.
to a
That's
physicist?
crazy. Yeah.
Right, like they're so intelligent, they're amazing to work with, they're so just like high level that like there's some questions that they'll ask me and I'm like, I don't know what you just said, but it's like so basic that it's like it's the most. I'm like, oh god, that's all you wanted to know. Like, but, like I try to maintain a good relationship with them to like try to make them like kind of like I try to humanize them a little more so they're not just robots.
Yeah.
But a lot of them are so sweet and very understanding. So like, with brachytherapy, I've had the ability, living in Pittsburgh, to be able to have such a great network within UPMC. They're a teaching facility. So what they do is they kind of let you kind of go into these, facilities and say, whether I am with X company or Y company, you have your clearances, you have your background. So they understand that you're right there to learn and I'm here to help. So a lot of my cases with that brachytherapy has been a lot of just learning at McGee, right? So you think when you go to
Right.
McGee in Pittsburgh, if anyone here is from Pittsburgh, we think a McGee Women's Hospital, that's where you're getting your gynecological care. That's where you're getting your breast care. That's where you're getting women's care.
Okay.
But they also, what they do, they have a radiology oncology department in the basement. And they do a lot of those prostate biopsies, those brachytherapy cases. So where they do, they implant the seeds, right? But at the same time, they can also do what's called HDR, which is high dose radiation. And they actually, it's kind of crazy. What they do is they actually they put needles in to a grid, and they say like this is where the areas are that we need to radiate, right? So say it was an anterior aspect of the cervix or the
Okay.
uterine wall or the prostate. And then they place these needles. What happens is they actually sew these needles in, they go to CT, and they get radiation in that exact area. So it's almost like a very direct, like radiation.
So the radiation activates the needles that are
Needles are like they're like they go in through the needles. So they're going like the radiation goes in through that and it's like very like developed
specific.
immediately right to that exact tumor or that exact area.
Okay.
And then what they do is they come in a couple weeks later and they get another high dose radiation.
Okay.
So whereas like the risks for having the seeds, the low dose radiation, that's where they say like you will go through an airport and you're going to set off the metal detectors,
Oh.
or you sit with your kids or somebody sits on your lap and they could be exposed to radiation
Oh, okay.
because you have low dose radiation seeds inside of your prostate or cervix or whatever it may be. The
So
the
how
issue,
long do they keep them in there then?
honestly, I've never seen them take it out. I think what happens is those radiation seeds have a shelf life, so they actually will go away for like I think they're only applicable for like 6 months. Don't quote me on that.
Okay.
But they actually lose their radiation
Okay.
throughout the time. But like when they initially go in, I mean, they bring them in these tiny little like they almost look like this. This is actually a Bath and Body oil, but it comes in these little tubes like this, and they're like little seeds, and they go
Huh.
boop, boop, and they pop them in with the physicists. Who the physicists basically outline the prostate and say, hey, or the cancerous area, and they say,
Okay.
hey, these are the areas that we need to dose at a higher rate versus an apical lesion. Let's get a base lesion and let's really hyper get that in, and make sure that we get as much concentrated radiation to that exact area versus just treating the prostate in a general whole.
Yeah,
It's very like condensed therapy.
that's awesome.
Yeah, brachytherapy is very interesting, and especially because it can be done in more than just one way. I think it's amazing that I never knew it was done in a gyne. I never knew this was even something that we did in the first place.
Yeah.
So to see it being done frequently and having great results like that's what else could we want?
Yeah. So I know earlier you mentioned a partial nephrectomy and to do, for renal stones, benign tumors, cancer, different things like that. And so they use robotics and laparoscopic equipment to remove those with under ultrasound guidance. Is that what you're telling
Yeah.
me? Okay.
So stones, right? So we get called in. Oh, there's a kidney stone. Oh God, can't you just do a CT? Can't you get an X-ray? Right?
Mm-hmm.
Oh, right. We're so annoyed to get called in for kidney stones. Or maybe there's some places that actually don't make you get called in for something like that. And bless those facilities.
Right.
Because realistically, an ultrasound is not, we all know an ultrasound is not going to tell you anything that a CT or an MRI won't, or an X-ray, right? So when we go into these surgeries to do stones, for instance, like a PCNL, a percutaneous like lithotripsy.
Okay.
So what they do is they use it almost sounds like a jackhammer, Debbie. Like I honestly was
I've
like,
heard
where am
them. I've heard them.
I?
I've
Right?
heard them.
They break
They
these
are
stones
loud.
up and it sounds crazy because you're over here just like, what are you doing? Like these stones are actually like serious. Like they're very calcified, massive, issues within the kidney that we think, oh, okay, it's just a stone. But realistically, I mean, they're hammering it out in the OR like they're hammering out a sewer. I mean,
Right.
it sounds
Yeah. I
crazy.
know. It sounds terrible.
Right? You're like, what is happening here? And then like I see chunks of the stone getting processed through their suction, right? And that's not something they do with a robotic surgery. That's an open procedure.
Right.
Where
Right.
they take like a nut, which a probe that we use, it's called like a probe. It's a curved probe, right? And so they can actually just put it right on here and say, yep, that's where we're at. We're in the, anterior lateral aspect of the kidney. We're putting it on, in their actual skin, right? So they use it skin on skin like we normally would, but it's the doctors
Right.
that are operating it. It's
Right.
not us in the OR. It's not, a sonographer that's saying, yes, that's the anterior or lateral aspect. That's the doctor,
Right.
calling that out. So it's definitely, and it's not a radiologist, it's such a different aspect going into the OR and it's, a general surgeon. And I'm like, do you really know what you're looking at? Like you almost kind of question it. Like, are you sure? Like, but you're never going to question a doctor, right? Are you going to?
No, I don't think I would.
Yeah,
Um,
I wouldn't.
unless I'm just asking to understand, right?
Mhm.
Not questioning what they're doing, but just questioning for my understanding, right?
Right. And I think that that's the most beautiful part of the medical field
Right.
is that, we're all always understanding and trying to get a better, well, show me a better way,
Right.
like let's teamwork this out. Let's figure it
Right.
out. Let's,
And I think as ultrasound techs, I don't think we've had ways open to us to give us permission to be creative, right? Like you mentioned earlier that you go into this place and work it out with a team of people, and how can we do this better and whatever. And I think we need to let other sonographers know that there are opportunities out there where you can go in and brainstorm and create and be creative and imaginative with how to better a procedure. Or I mean, you can make a lot of money off of a new idea of an
right.
invention, and I think we don't think about that. We're so stuck in the rut of the routine
Mhm.
day to day that if we take the time to be creative and restful and whatever, and be curious, well, what about this? Well, let's try that. Well, let's try this. And I know some doctors have asked me to try different things, and I'm like, okay, well, we can try it. And
Right.
I try it and I'm like, oh, well, I'll be darned. Look at
Well,
that.
that sure did work, didn't it?
Yeah.
Like, okay, then fine.
Right? And you learn something new and you learn something to pass down to somebody else, right?
Exactly.
And,
And that's what the medical field is, right? Do one,
well,
see
I
one, teach
hope so, right? Not every place is like that, right?
one.
And so it's good that our newer generation who's coming in is more willing to do that, right? Like
Right.
it's we're all learning the same thing. For me to know it and you not to know it does not serve me or you or our patients, right?
Right.
So I think the younger generation is really grabbing hold of let's share this information together,
Hmm.
you know, but also let's be curious. Let's get curious and say, let's go and spend our extra time off and go somewhere to figure something out, to
Hmm.
reach out to somebody to say, oh, you're involved in this. Well, can I brainstorm something with you? Or can I come up and spend a weekend with you and we can work something out? Or, I mean, I think we need to just be curious and willing to reach out and ask more questions, you know,
Exactly.
because, I used to tell when I was raising my kids, there's more people out there who want to help you succeed than there are people who don't want you to succeed.
Exactly.
you
You're
know
right.
and so I love um being in a group where everybody can bring a part for
Hmm.
it to be successful you know
Exactly.
and so I love that. I love that about ultrasound, and I love that we're constantly learning, and technology is changing and we learn some more, and technology changes and we learn some more, right? So
Exactly.
I think it's an amazing occupation that you and I have both chosen that can take us so many different directions. And I think when I first got into it, I didn't realize that there were so many options of things that we could do with it.
Right.
And
Right.
so now I think there are becoming more and more options for those things, you know.
Exactly.
And
I don't want to say like the older we get, but the longer we spend in the field.
yeah.
I'll say it that way. The longer we have spent in the field, we see, and I think as travelers, right, we
Right.
see how different facilities use different protocols, or they have different, CPT codes. So they have to do this different or this different. Like things are different all over the country.
Yes.
So even from, the northwest to the southwest, right? Like I mean, and that's
Right.
even different. Like northeast to the southeast, like there's a whole different demographic you're dealing with.
Right.
So a lot of that as a sonographer, and even just learning, right? Like it
Right.
is a beautiful thing. And I have always hated people. I don't care who you are. Like I hate you if you're going to be mean to people that are going to ask questions and try to better themselves. Like
Right.
people that just want to learn and people that are going to try to they're just here to understand. Like I hate the people that are going to, shoot them down or not help answer that question. Like that's what we're all here for, right? Like
Right.
we're all here for the same common goal. Want to help people.
Yeah.
So
Yeah.
where
And
it
so
comes
let's
in
do it
between,
together.
right?
Let's learn how to overlook our petty differences, and our hurt feelings for the common good, you know?
Right. Like just go do that portable exam. Like just go. Like it's not going to be that big deal. Like just go. Take that
Right.
extra procedure. Stay late and do that extra patient. Like just shut up and do it. And I think a lot of that stuff, and like I don't know if that's just me as like the person I am as a worker, but like I just, we all know the person that clocks out at that time, right? And they're done, they're out the door. They're
Right.
usually the lead tech, right?
I did not say that. I did
Right?
not
No,
say
I'll
that.
say it because I don't have to be in front of
I did
ultrasound.
not say that.
It is usually the lead, right? And they're out the door, they don't care. And you're just sitting here like, well, I feel like, this should be done differently, or this should be that, or the protocol should be different. But like, and that's what I love about the medical field and where I have transitioned my career to, is being able to see people that are just also so passionate about, the surgical side of things, or where we can take ultrasound to, where it's not just, okay, we're bedside and yes,
Right,
we diagnose. I mean, we don't technically diagnose,
right,
but
right,
our ultrasounds diagnose these problems. They diagnose the disease process X, Y, and Z.
right.
But let's take it a step further and see what happens outside of that. So where we turn around and have that surgical outlet, and it's incredible. I mean, ultrasound is used in brain surgery. It's used in spinal surgery. It's used in every aspect of surgery that and as sonographers, we're just like, oh, it ends with us, right? It ends with that radiology. The radiologist says we recommend a CT, or MRI or additional imaging to compound with the ultrasound,
Right,
because they're not just going to do a surgery based on that, right? Like, say they
right,
have appendicitis, they're going to do a CT,
right.
right? They're not just going to say, yep, that's God, right? That's it, that's Bible, we're good. Like, they're never going to just take
Right,
ultrasound for what it is. And it
right.
almost is almost
Well,
insulting.
it helps to have, just like in ultrasound, you have to have more than one, you have to be able to reproduce what you're seeing in more than one
Right.
angle, right?
Like you said earlier, you were talking about just like even just other people kind of seeing each other's work and doing that weekend kind of abroad or whatever. Like with
Right.
Laura, like I would love to go spend a week with her and learn everything she knows about pelvic floor. I mean, that is such an understudied, you know, aspect of women's care that really, really, it's incredible. Honestly, like I was actually really floored by that podcast. That was a fantastic podcast for you and for you ladies to do. That was incredible.
Thank you. Yeah.
I learned a lot from it. So
Yeah,
I
and so that's the beauty, and that's the reason why I decided to do a podcast is let's just share what
exactly.
everybody's specialty is, and let's get your name out there so that if someone is curious or does get curious, they're like, huh, I wonder if she might have something I could, ask her about. I wonder if her modality could help my project or something. I think
Exactly.
when we get burnt out from doing the same thing over and over, I wonder if we got involved in our organizations like SDMS or things that we could see. Getting involved in SDMS has helped me to see things more globally,
Hmm.
right?
Globally is the key word.
Globally, right? Like, oh, I met her and she does amazing pediatric work at blah, 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 right? And so then when I'm talking to somebody, I'm like, oh, let me help you connect you to somebody I know.
Hmm.
So I don't know. I just think when we get burnt out, we just need to maybe broaden our horizon and see where we fit and can contribute to our society or to each other more on a global level. You know,
You're exactly right. Yeah.
it's a
I think
beautiful
that's
thing. Thank you
important.
for your excellent presentation and thank you for sharing your expertise with us. It's been fun to talk to you about new and different things that we never see on a routine basis. And that it's out there, right? That there's new things being developed and made and put into place to um, give better service to our patients, which might eventually someday be us, right?
Exactly. I mean, we
So,
all know.
yeah, I think we have to keep that in mind. This could someday be us. So,
Or someone that we love, right? I
someone that
mean,
we
that's
love.
how I treat every single one of my patients is this is somebody I care about. This is somebody that I know, like, especially a lot of my accounts around here is, these are people that in this area that I live in that are going to be affected by,
Absolutely.
certain things. So I
Right.
want to make sure more than anything, obviously,
Right.
more than anything with anybody that's going to be utilizing or using these machines and going into the OR or whatever the case, I want you as a doctor or as a nurse or whomever to use this to your best ability,
Right.
because like that's my neighbor, right? That's
Right.
my mom's friend. That's somebody I grew up with. That's my softball coach, right?
Right.
Like that's the people I grew up with. Like it's a
Absolutely.
smaller city that I live in, and the hospital network that, encompasses us
Right.
is all encompassing, right? Like they're nuts. Like you can't get
Right.
away from it. So at the end of the day, like a lot of that is a lot of people coming together and combining resources and talking about, what the best practices are. So, that comes in with teaching,
Right.
right? And it's making sure that, like, I mean, a lot of the times you're teaching a nurse that couldn't care less
Right.
about what's a frequency. Like we don't care about a 12 megahertz frequency versus 6, but
Right.
that matters
Right.
when you're in, a partial nephrectomy
Right.
and the tumor may be more superficial. So let's make sure we have a 12 megahertz, right?
Right.
But like explaining that
Right.
is so difficult because it's just not a nuance that they would really actually care about in that surgical aspect, right? They just want to see exactly what it is.
Right.
So making sure in my, position that I am now and in the career that I chose, making sure that doctors are well equipped, they're well educated, they know how to use our machines, they know how to use our equipment, and they know how to make the best, so that they know how to make the best outcome for their patient, which
Right.
is what we're all here for, is better outcomes for patients. Because like you said, who knows if it's going to be me or,
Right.
you or your
Or
mom.
give them resources. You're a great
Mhm.
person to provide resources too, right? So
Exactly.
thank you so much. I really appreciate your contribution here with your podcast and sharing your expertise. And I know it'll help a lot of us out there in the
Yeah,
future.
because our work does matter. Our bedside work matters.
Yeah.
It really, really does. So I know that like a lot of us think like, oh, they're just gonna get a CT, but it really does matter. They go into the OR, they use our ultrasound, they use us as sonographers, they care. So it's important that we're making good diagnostic imaging at that bedside level, and especially after that. So I really appreciate you shedding light onto this and having that ability to be able to have this conversation, that we can even have a really intricate conversation about surgical ultrasound. It's important, and I know a lot of us don't love the OR. There's only some of us that do. But it is so important. It is very important, and having those relationships with your surgeons is also very important. So, you know, reaching out and making sure, like, this is a network, and I love that you're having that. That's amazing. Like the network that you're establishing, that's like the best thing you could ever have, is sonographers being there for other sonographers in such a different outlet.
Right.
So I really appreciate what you're doing. This podcast is nothing but fantastic and
Thank you.
educational. So I really, really applaud you for everything you've been doing. They're great. So congratulations. Thank you for having me.
You're welcome. Thank you for being a part. Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.